Welcome, everyone. We're going to let everyone get signed in here, and we'll get going in just a moment. Thank you. All right, I think we've got a few people still trickling in, but we're going to get started here. We'd like to welcome everyone to today's Post-DDW Functional GI webinar. I am Jason Abrahams, and on behalf of Commonwealth Diagnostics International and MyGiHealth, we're excited to host what should be an energized discussion on some of the newest trends and hottest topics for the GI community. CDI's mission, our host today, is to help providers better identify and diagnose common sources of digestive distress and functional GI ailments, with a focus on developing a portfolio of non-invasive and cost-effective diagnostic solutions that result in an expedited treatment, better patient outcomes, and robust cost savings for the entire healthcare delivery system. CDI's expansive portfolio includes non-invasive at-home breath testing for SIBO, IMO, and carbohydrate malabsorption disorders, as well as IBS check, proprietary capillary collection test for IBS, and MyGiHealth, a cloud-based healthcare platform that enables patients to manage and understand their symptoms while enhancing the patient-provider relationship. CDI is also at the forefront at GI research, working directly with sponsors, CROs, and principal investigators of clinical trials worldwide. You can learn more about CDI's diagnostic products and solutions at comdx.com. And just a little housekeeping before we get started. Today's panel is being recorded and will be available for registered attendees afterwards. And if you have questions for the panel during the conversation, you can type them into the chat box in your Zoom control panel. We'll bring them up during the discussion, and we'll also have time for additional questions at the end. And now, without further ado, I'd like to introduce our esteemed moderators for today's panel. Johannah Ruddy is a national expert, academic researcher, and writer on teaching communication skills to patients and providers, and currently serves as executive director of the Rome Foundation. She has authored and co-authored 12 articles on IBS, navigating the healthcare system, and the role of gender bias in healthcare. And her new book, co-authored with Dr. Douglas Strassman, titled Gut Feelings, Disorders of the Gut-Brain Interaction, A Guide for Patients and Doctors, is now available on Amazon. She holds a Bachelor of Science degree from the University of New Mexico and a master's degree from New Mexico Highlands University, and is currently pursuing a PhD from the College of Health Science at Campbell University. And Craig Strasnick is a seasoned executive, experienced entrepreneur, and dynamic commercial leader. In his current role as president and CEO of CDI, he partners with respected academics and industry leaders across the world to improve current GI practices. He drives the company's mission by developing and introducing new patient-friendly preventative health and monitoring technologies, as well as ensuring their clinical and commercial execution. He's a graduate from Northeastern University and is also a current board member for Functional Gut Diagnostics, a CDI joint venture in the UK, MyTotalHealth, a developer of the MyGiHealth platform, and GI Logic Inc., the creator of AbStats, a non-invasive GI biosensor device. Johannah and Craig, it's great to have you here, and I will leave it to you.
Great, thanks, Jason. I really appreciate that introduction, and I will go ahead and kick off our introductions this evening for our esteemed faculty. So first, we would like to welcome Dr. Shanti Eswaran. She is a gastroenterologist and a clinical associate professor of internal medicine at Michigan Medicine. She completed both her medical degree and internal medicine residency at the University of Michigan, and then went on to pursue her fellowship in gastroenterology at Columbia University Medical Center with a clinical and research interest in celiac disease and functional GI. Dr. Eswaran served on the faculty at Northwestern University in Chicago until she returned as faculty to the University of Michigan in 2009. She has research interests in the role of diet and food in functional bowel diseases such as IBS, and complemented by her clinical interest in functional GI, celiac disease, and non-celiac gluten sensitivity. Dr. Eswaran currently serves on the Food and Diet Working Team for both Rome 4 and now again for Rome 5. We're so pleased to have her back. And she has several grants that are supporting this research. So welcome, Dr. Eswaran.
Thank you so much.
We also welcome Dr. Rajiv Sharma. He is an integrative gastroenterologist and researcher and founder and president of Digestive Health Associates in Indiana. After attending medical school in India, he received his internal medicine training from Loma Linda University and his gastroenterology fellowship training from the University of Rochester. Dr. Sharma's special interests include GERD, NERD, IBD, IBS, acute and chronic pancreatitis, gastrointestinal malignancies, and familiar cancer syndromes. He believes in whole person care, which I like to refer to as the biopsychosocial care model, and loves to talk about its effect on the mind, body, and spirit and in relation to wellness. He has a special interest in nutrition, exercise, and healthy eating. And to share his extensive knowledge with the public, Dr. Sharma released his first book entitled Pursuit of Gut Happiness, a guide for using probiotics to achieve optimal health in 2014. Dr. Sharma, welcome this evening.
Thank you.
Well, thank you so much, Johannah. Thank you to all of our panelists and attendees for joining us here this evening. I have the privilege of introducing Dr. Brennan Spiegel. Dr. Spiegel is the Director of Health Services Research for Cedars-Sinai Health System. He's also the Director of the Cedars-Sinai Master's Degree Program in Health Delivery Science. Dr. Spiegel directs a multidisciplinary team that investigates how digital health technologies, including wearable biosensors, smartphone applications, virtual reality, and social media can improve people's lives. He is listed in the top 100 influencer lists for digital health and virtual reality, and his digital health research has been featured by major media outlets, including Bloomberg, CBS News, Forbes, NBC News, Reuters, The Washington Post, and The Wall Street Journal. His virtual reality research won the 2017 Webby Award for Best Technology on the Internet. And in 2020, he published the book, Virtual Reality VRX, How Immersive Therapeutics Will Transform Medicine. Dr. Spiegel is editor-in-chief of the American Journal of Gastroenterology, the leading clinical gastroenterology journal in North America, and was among the first group of clinical researchers to examine the gastrointestinal manifestations of COVID-19. With that, we welcome everyone again, and I will hand it back to Johannah to begin our questions.
Wonderful, thanks, Craig. Okay, so a great panel of experts with us this evening. So let's dive right in. We have some great questions. So first, I guess, let's start with Dr. Sharma. Why don't you kick us off with this question this evening? We know about the increased stress and anxiety that everyone's been facing during COVID. There's been issues related to alcohol and food consumption during this time. COVID has had a very clear impact on the entire healthcare system, and it's an ongoing concern for the GI community. What do you think about research in relation to this? What is research showing, and what are you seeing personally with your patients and how they're dealing with these issues related to COVID and their maybe GI manifestations or their overall well-being during COVID times?
Sure, great. Thank you, Johannah. With COVID, what I have seen is because of increased stress and there's associated anxiety along with the increased intake of alcohol, tobacco, and other poor dietary habits, people are having a lot of flares of IBD and also IBS as well. So frequently I got calls to my office for, my bloating is worse, my diarrhea is worse, I don't feel good, can you refill my Bentil, etc. And then I also saw that people who actually had COVID, they actually had more GI symptoms than people, who did not have COVID. So definitely I feel that COVID somehow affects the enteric nervous system as well, increasing the GI motility. So along with the infection by the virus, paired with the stress that's associated with COVID and the poor dietary habits, I think it just served as the perfect storm for people to have a flare and kind of have a have very, very upset GI system.
Yeah, yeah. So how are you treating that? What are your recommendations for these patients that are coming in with this exacerbation of these symptoms?
A lot of times I ask them, of course, their stress levels. Number two, if they're drinking more alcohol or they are vaping, because, when they stay at home, they pick up bad habits. And people have recently picked up a lot of vaping, especially in Indiana. There's a lot of vaping, a lot of marijuana use. So when I see there's a factor which is extrinsic in terms of a toxin they're ingesting, I like to make sure I stop that. But I still kind of walk myself through the same diagnostic algorithm, making sure it's not C. diff, making sure there's no stool infection with E. coli, Campylobacter, and things like that, which could be related to food intake. And after I have ruled out the infectious component, for symptomatic treatment, I have given people trials of Flagyl and Cipro, as well as I have them take some Pepto-Bismol to see if they'll cool off their GI distress. I had some very good success with Pepto-Bismol and also giving them a touch of Flagyl, about like 250 milligram PO 3 times a day for 14 days. That was my magic cocktail. It worked very well. In some cases, I gave them antispasmodics like Bentyl and Levsin. So I got very good results with that. And then, of course, in terms of kind of behaving properly and cutting back on alcohol, marijuana, vaping, stress management, that does go hand in hand along with these treatment options.
That's great. Thank you, Dr. Sharma. Dr. Eswaran, I'd like to ask you the same question and maybe even add to that with your expertise in celiac disease and non-celiac gluten sensitivity. Did you find that some of your patients had maybe more difficulty with their diet during COVID times, maybe not having access to the right kinds of foods, or if they are, on a gluten-free diet, they weren't able to find those types of foods as easily?
Yeah, thanks for the question. So it's really sort of interesting. I mean, I hear what Dr. Sharma is referring to in terms of an exacerbation of IBS symptoms. But what I've also found is that a really large, significant minority of patients are actually telling me how well their IBS is behaving during this time period. And that's because their daily stressors of commuting to work, social events, travel are not there. And there was actually at least one, maybe two abstracts at recent DDW kind of looking at this and also focusing on the sort of relief that came with telehealth for these IBS patients as well, with lack of travel and the kind of along the same lines. So I've actually seen in general, probably the prevalence of or incidence during COVID of IBS has increased, but the patients who already had IBS, they're actually doing slightly better, at least those in my clinic. And that's because some of the external stressors that they couldn't control are actually now under their control. What with working from home, not having to deal with coworkers or workplace politics, family politics. So that's really something I've noticed. And to answer your question in terms of diet and access to food, patients are having time and the opportunity to choose what they eat for all the reasons I mentioned. And so they're actually finding it more, it's more easy to stay on the diet that works for them, whether it's a modified low FODMAP, low gluten, et cetera. And so that's kind of what I've seen. And I think that some of the data has borne out. In terms of the post-COVID or COVID-related GI symptoms in particular, I think that there was one abstract as well at DDW that looked at the ongoing symptoms of ongoing GI symptoms after acute COVID infection. And it really does seem to act like post-infection IBS in some way. So the patients that are more likely to get post-infection IBS are also more likely to get post-infection IBS from COVID. So those with a history of post-traumatic stress disorder, early adverse life events, for example, those are patients that are probably more likely to at least have long-standing or lingering GI symptoms related to the acute COVID infection.
Yeah, that's interesting. Dr. Spiegel, I'd like to transition that over to you. You've done some research in COVID and patients with GI manifestation. I know, we've talked before that you have seen an uptick in patients reporting some of this post-infection type IBS or post-infection dyspepsia. Can you talk a little bit more about that and what you've been seeing?
Yeah, sure. Thank you. So this has been a wild ride for all of us this past year. And in gastroenterology, if we go back in time a little over a year when this started, the New England Journal put out a paper about COVID-19, and it became a landmark paper. And in that paper, they described that GI side effects or GI symptoms occur in 3.8% of people with COVID-19. And when that was published, we thought, oh, well, I guess this isn't a GI disease. This must just be a pulmonary disease and a respiratory illness. And that seems like it's so low that if somebody has GI symptoms, we can maybe rule out COVID-19. Well, it turns out that was dead wrong. I mean, just absolutely wrong. And what we've learned since then, and early on, not long after that was published, is that on average, about 20% of people with active COVID, we'll get to the post-COVID in a moment, but just with active COVID have diarrhea, and about 50% have one or more GI symptoms. And I was on one early paper that kind of described that from the original cohort in Wuhan, China. And what we've learned since then is that COVID-19 is an enteropathic virus. We know that it enters the body through the ACE2 receptor. And of course, ACE2 is found throughout the lungs. But if you really want to find ACE2 in the body, you go to the gut. 100-fold higher density of ACE2 receptors in the gut than in the lungs. It's like Velcro. So if you can swallow COVID, which people do, because it sheds into the saliva, and if it can make it through the acid layer, which it can, particularly if somebody's on a PPI potentially, and it gets into the gut, it just enters the largest immune organ in the body, and it sets up camp. And we now have extensive evidence that this is what happens. And it could potentially, and it seems to spread from there, even to the lungs. That's called the gut-lung axis hypothesis. So even in acute COVID, we've come to realize it is an enteropathic virus. It causes diarrhea, causes abdominal pain, causes ischemic colitis through alternative mechanisms. And when people recover, we are clearly seeing persistent GI symptoms in many of them. And the abstract that we published last week at DDW looked at the changes in the prevalence of IBS over time. And we are seeing an uptick in the prevalence of IBS in the general population. Now, it could be a post-viral form of IBS, or it may be stress-related and not intrinsic to the virus itself, or any of these other factors we've talked about today, environmental, food and ingestions. We don't know, but we are definitely seeing a higher prevalence of IBS and a functional dyspepsia, not necessarily of other functional GI or disorders of brain-gut interaction. So this is very, very important and something we are continuing to monitor. I know the Rome Foundation is as well. And we're looking month over month, we're repeating this national survey to see if there are trends over time.
That's fascinating. I know we're going to see a lot of very interesting data in the next coming 6 to 8 months on that too. Thank you. I'd like to move now to, we talked a little bit about the role of diet. Let's get a little bit deeper into that. So there were some posters presented last week at DDW talking about the role of the low FODMAP diet as a first-line treatment approach for IBS. How does that work? What are your recommendations with your patients? Do you use a low FODMAP diet as a first-line approach for your patients after diagnosing them with IBS? Do you find patients are amenable to that kind of a treatment approach? Do you think data supports it as a first-line treatment option? Dr. Sharma, would you like to take that first?
Sure, absolutely. I'd love to. Thank you again. In my personal experience, having trained at Loma Linda and looking at the whole person care and mind-body medicine, I always like to try diet first. for anybody with IBS symptoms. I'm a big diet guy. So in my practice, I have had very good success with low FODMAP diet. And when I look at low FODMAP diet, what I see and what I observe is just a very clean, hypoosmotic, kind of a hypoallergenic, non-toxic type of a molecule, instead of just having all the preservatives and everything else which is found in the stores for people who are sensitive to lactose or even inulin or anything which will be as part of the diet. What I feel is with low FODMAP diet, things are so strict that people not only they have a placebo effect that, boy, I'm doing something very careful, so I feel better already. That's number one. But I have seen measurable improvement for my patients. For example, I had this lady with bloating for her entire life. We did the entire workup of celiac disease and Crohn's disease and everything on her. Everything was negative. We checked our pancreas for EPI, that was negative. So when I put her on low FODMAP diet, I discovered that she was feeling better, and she actually was reacting to garlic and onions in her diet, and then she miraculously got better. So I definitely use that in my practice quite a bit, and I preach it pretty aggressively. And the data is very strong too,
Are there certain symptoms that your patients come to you with that you identify as being good candidates for a low FODMAP diet? You mentioned bloating. Are there other symptoms that kind of ring true as being receptive to a low FODMAP approach?
Absolutely. So, I practice in Indiana, about 1 hour from Indianapolis. So my classic IBS patient or a low FODMAP candidate will come in and make the following statement: "Doctor, I feel I'm 9 months pregnant. That's it." So I actually have a protocol which I say, "Doctor, I'm a 9 months pregnant" protocol. So when they come in with that protocol, we'll come in with those questions, symptoms, I know they'll be receptive, because that indicates their own perception of their body and the fact that they no longer can fit in the bikini or their wedding gown or any other dress which they like, and they can no longer go to party with their friends, and they're kind of ashamed of their symptoms. So that kind of patient who perceives IBS as a beauty, as a social type of issue, they're very receptive and very motivated, and we enjoy working with them because the first symptom which responds in my diary is bloating. That's the one I feel responding pretty quickly. Number two is, belly pain and cramping and diarrhea. We have a lot of IBS with diarrhea in this part of the world. Then the second thing which I see improving is the belly pain, the discomfort, and then the diarrhea. So that's how it's here. Yeah.
That's great. Thank you, Dr. Sharma. Dr. Eswaran, I know at Michigan Medicine, you have a very integrated approach to patient care within your GI clinic. So your patients are, if a diet therapy is an option, a good option for them, then you're working with them with a GI dietitian as well. How important do you think it is for GI patients to be working with a GI dietitian when you're looking at an elimination diet in terms of screening for potential eating disorders or ARFID or other things that might come up as then being counterproductive to that diet therapy?
Yeah, thank you. So I will say that I do feel blessed and lucky and probably somewhat spoiled to have very skilled and invested GI dietitians who not just understand irritable bowel syndrome, but the whole gamut of GI related diseases. Which of course overlap, but are also fairly nuanced. And there's data to support that working with a registered dietitian who has an understanding of both the low FODMAP diet, but also other possible diets, including a low histamine diet, gastroparesis diets, et cetera, will improve outcomes and will improve adherence and improve kind of overall success in terms of response. So I feel like it's invaluable. I understand though that kind of approach isn't for every patient or gastroenterologist, depending on what practice setting they're at. I think that diet for IBS is incredibly powerful. It's a GI related disease. So of course it's going to be affected by the process of eating, so food itself, but also what goes into your body. But it's not for everyone. The low FODMAP diet is at least first glance, like, incredibly restrictive and daunting. It's a time commitment. It's at least, a 6-week to 12-week kind of commitment to go through all the 3 stages of that. And some patients aren't interested. They can't afford it. It's too busy. And they want another approach. And thankfully, IBS is a heterogeneous condition. And it's kind of driven and exacerbated by a lot of different avenues. And so we can work with a GI psychologist or work with neuromodulating medications if stress or anxiety is playing a role. We can talk about microbiome. So I use it a lot, obviously, given kind of my research bent, but I think that it's kind of like not the only approach, and it's not my first line in any or even most patients based on the kind of people I see.
Interesting. That's great. Thank you. Dr. Spiegel, I know at your clinic, you might be seeing a little bit more of a severe patient profile. How do you integrate diet therapies, or do you even use diet therapies with your patients?
Yeah, absolutely. I agree with a lot of what's been said here and the importance of diet. And also the idea of multidisciplinary care is really critical, whether it's working with nutritionists, psychologists. We haven't talked about, cognitive behavioral therapy, for example, today, and other types of professionals who have expertise. Even though I'm a gastroenterologist, I really don't feel like I have deep expertise in diet. I know about the FODMAP diet. I often will recommend it. When I do, by the way, I refer people to a dietitian whenever I can, and to a website that we created with Bill Che at the University of Michigan. It's called MyGiHealth. And this was a website we created to help patients work through the FODMAP diet. Because as we know, it's not at all trivial to follow the diet. And it's sometimes even harder to come off the diet, to figure out systematically which one of those FODMAPs, as Raj mentioned earlier, is the culprit. To do that really takes tremendous amount of time, focus, almost grit, frankly. And it's something that requires coaching, information, education. So it's not a trivial thing. And I think that's very important. Unlike taking a pill, which requires you put it in your mouth, a diet is a very, very different type of therapy, and one that requires expertise. So that's sort of my thoughts to all this, is just to reinforce what's been said. And also, we have this website we created years ago, MyGiHealth. You could check that out if you're interested. It's full of videos and kind of step-by-step guides for patients. It's certainly not a substitute for a nutritionist, however, or a dietitian.
That's great. Thank you, Dr. Spiegel. Okay, I'm going to turn it over to Craig, and we'll move on to the next set of questions.
Excellent. Thanks so much, Johannah. Those were very insightful answers, very fascinating. And we've talked a little bit about current practices and things that are being used in clinic today. What I'd like to do is switch gears a little bit and talk about some of the technologies of the future. So my first question is, there's been a lot of talk here lately about the application of next generation data science, things like machine learning and artificial intelligence, and next generation technologies like virtual reality and GI. I'm wondering, do you see any promising early applications for machine learning or artificial intelligence in functional GI or GI more broadly? And if so, which areas? And kind of branching out further from that, virtual reality, how far away are we from clinical use and best practices in that regard? I think probably Dr. Spiegel, I know you have a tremendous amount of domain expertise in this area. So I think probably we'll start with you, and certainly Dr. Eswaran and Sharma. I'm very interested to hear your thoughts here as well.
Yeah, thanks, Craig. So that's a big topic. So I'll try to just, answer it briefly. Maybe I'll just start with virtual reality for a moment, because that's an area I'm particularly interested in. Most people, when they think of virtual reality, they think about, a gaming platform for kids, for entertainment. first-person shooter games, these sorts of things. And it's pretty incredible. But it turns out long before VR was used for gaming, it was used in psychology laboratories in elite universities around the world for years to help sort of nudge the mind in positive directions, to help support mental health, to help people meditate, to help people deal with fears and anxieties in a way that's really quite remarkable. And we've been using virtual reality for many years now for pain management, both acute and chronic pain. And there are now actually thousands of studies supporting this, including many randomized controlled trials. So the question is, okay, if it works for somebody with a broken leg, which it does, we've shown this, or somebody with cancer-related pain, can it help with visceral pain in people with disorders of brain-gut interaction? Virtual reality, won't necessarily change microbiota. I don't know, maybe it will, but probably not, through cortisol changes or whatever. It's not going to necessarily cure, IBS or functional dyspepsia, but it definitely can help support patients. And, we've been developing a virtual reality treatment for IBS that teaches cognitive behavioral therapy in these VR worlds, allows people to do gut-focused hypnotherapy in these beautiful, fantastical worlds. And I always say, rather than always bringing patients to the clinic, maybe we can bring the clinic to the patients. And with VR at home, people have access to an entire virtual reality clinical environment that they can explore on their own, in their own time, in the privacy of their home. So that's the virtual reality side. And, I'll stop talking here in a second, but you've tapped into something I'm rather interested in. And, AI is a whole other interesting area, and is being used in gastroenterology. Like, we're starting to see AI, especially for colon cancer screening, which is a different topic. But we now have pretty good data that AI can help identify polyps in the colon, for example, at a higher rate than humans can, and can augment and supplement humans doing colonoscopies. There hasn't been as much yet around IBS, either diagnosing IBS or other functional GI disorders or disorders of brain-gut interaction or gut-brain interaction. But there's really interesting data now. I'm even seeing data that, AI can look at an EKG and diagnose somebody with cirrhosis. I mean, it's incredible. So this is a really important area that needs a lot more research. And I think we're going to be seeing more and more algorithms that can help us both diagnose and figure out how best to manage patients using the metadata that we can collect and analyze with AI. So time will tell.
No, absolutely. That's tremendously fascinating. I appreciate that. And I think just as a follow-up there too, one of the things that we see so often at CDI is just functional GI patients and GI patients at large just being their own biggest advocates. They are going through a frustrating process. It's a difficult journey for the GI patient, and they're always out there trying to seek new active information, but things that can be benefactors to their care long term. So I guess just as a follow-up question there, are there any thoughts that come to mind about what the GI patient can kind of do on their own accord to play a more active role in this process, to be a part of some of these new technologies that might be able to make a difference in their long-term care?
Yeah, and I neglected to mention, we actually had an abstract at DDW last week where we showed that virtual reality has some benefits in patients with functional dyspepsia. Showed pretty significant drops in PAGI SIM scores across multiple domains for those that know that outcome measure. We need more research to demonstrate durability of response. But we have a website with that is not supported by any companies. It's purely from our own group here at Cedars-Sinai, where we have a list of our favorite VR programs for people who are interested in this. So it's called virtualmedicine.org. And it's a pretty comprehensive website, and we have some clinical resources. And we have a list of about 20 different VR programs that are available, some through prescription, some directly through VR headsets. Like if you own an Oculus headset, for example, you can download a number of different programs. None are gut specific. That's what we're building right now at Cedars-Sinai. But yeah, people want to get involved in this can already, if you have a headset or want to buy a headset, can use it not just for gaming, but actually for meditation, health and well-being. And we have some recommendations on that website.
No, that's tremendous. Thank you very much, Dr. Spiegel. We appreciate that. And Dr. Sharma and Dr. Eswaran, I'm wondering kind of same questions to you, how you see some of these technologies playing a role in your clinical practice overall, and as a secondary or follow-up to that, just how you think patients might be able to get involved on their own if they're not already.
Sure.
Well, I don't have nearly as much experience, obviously, compared to Dr. Spiegel surrounding this, but what I loved hearing is the fact that we know as practitioners that visceral pain, visceral abdominal pain is the hardest symptom to treat, regardless of even what your disease process is. And, you know, our medications can speed up or slow down your bowels. Sometimes we can give antibiotics that might help temporarily with some of these things. But pain is so hard. And what I loved hearing is that really the purpose of these technologies is really to target that. And I think that probably not just next generation research, but all research in general for irritable bowel syndrome should really be focused on visceral pain. And so I really enjoyed hearing that, and I can't wait to see what's next.
Oh, that's great. Dr. Sharma, please.
Oh, absolutely. Again, you know, it's always fun listening to Brennan. You know, every time he talks about VR, you know, I kind of get excited. You know, so I actually thank you, Brennan, for all the excitement and the knowledge sharing.
That's right.
You know, I personally, I'm a big fan of AI, also AR, something called augmented reality, which I think goes hand in hand with what Brennan has, you know, VR and AR. And one of my friends actually in Indiana, he came up with this app. I forgot the platform, where you would just scan a flower, and now the flower literally will show up on your screen, and you can spin it and you get engaged with it. So, you know, people get very calm when they are in their own little ecosystem. So I always feel the VR, AR, all these things are just ecosystems, or maybe a place where people find solace. You know, it's like their own little monastery. They just sit down there, they're calm. And this is the movie where they are the hero. They are the Rocky, they are the Rambo, they are the, you know, Terminator of this movie, where it's all about them, and they feel like they're in a small cocoon of comfort, where, you know, as they walk through this ecosystem, they are in control, and that I feel also has a good effect on their psyche, and they tend to calm down. So I see a big role for VR, AR, and then of course, you know, AI for multiple other things in GI. Another thing which I'm a big fan of is, you know, using digital therapeutics, right? Everybody has a cell phone. Some people have two. And that itself puts more control in their hand. And I feel that the more people take control of their symptoms and their care plan, the more they can indulge and also immerse in their care. And that leads to a very successful and satisfying medical healthcare transaction with the physician or the healthcare system, where I think their satisfaction scores go high. Because a lot of times these patients feel like nobody's listening to them, right? Oh my God, I'm 9 months pregnant, I'm bloated for my entire life, and can go to this, that, and they always, you know, sad about it. But I feel with all this technological developments and these tools, it puts the control back in the hand, and now it becomes very patient-centric. That itself has a healing effect. So that's my take on this.
No, that's very, very helpful. I guess, and just a quick follow-up there, maybe start with you, Dr. Sharma, but open up to the panel as well, is, you know, this idea of immersive and integrative care for the same patient with, you know, degrees of comorbidity across a lot of different disease categories in GI. I'm wondering if there's any best practices or supplemental tools that you're using now that you might know of in the marketplace, or have created utility for some of these patients as they go through what we've already said before is a pretty frustrating journey.
Sure, absolutely. You know, for me, in terms of you know, tools, I'm assuming you're talking about probiotics and other things, right? That go with it, or you just are looking at.
Of course, anything, digital approaches, any therapeutic approaches,
Sure.
anything that, you know, you've seen work with any level of consistency.
Absolutely. You know, in my experience, and I'll wait for what Shanti and Brennan have to say about this, but I'm a big fan of probiotics. That's why I wrote the book on probiotics, you know, because I've seen them work. You know, I'm from India originally, And not only we invented yoga, we also believe in very healthy eating, clean eating, along with the cultured foods and fermented foods. So yogurt, we make our own yogurt at home. And so just from that mindset, I believe in food being a good tool to connect with the patient. Because, most people in my demographic here, they want to try a non-medicinal route first. They want to use pill as a last resort. So that helps me strike a rapport with the patient when I say, well, let's try something natural. So, sometimes I have tried maybe healthy probiotic drinks like kefir, and I have tried in some people sauerkraut. And then for people who don't want to go for foods, I have tried probiotics. I have used this medical food called Visbiome. That was originally, it had a different name, VSL number 3, but now it's Visbiome. I have very good success with that, especially for bloating and abdominal pain, magical success. A little trick I use once in a while is I use activated charcoal for bloating and gas. A lot of these people, when they take activated charcoal pills, it absorbs the gases in the belly and the bloating goes down and they feel pretty good about it. And if everything else, and then of course I use, rifaximin and Flagyl and other antibiotics as needed. Then I complement that with, for the last few years now, with food allergy testing. I actually have made food allergy testing a big part of my my recommendation for my patients. I work very closely with dietitians and an allergist. And I've seen that a lot of these people, they have asthma-like symptoms and they also have GI distress. I have picked up many cases of egg allergy, shrimp allergy, tomato allergies. And when I remove those food items, not only their GI symptoms get better, but the global symptoms also get better. So that to me has really helped my practice quite a bit.
No, that's great, Dr. Sharma. Thank you. I know I want to make sure that we have enough time for the Q&A. We have some questions here in the chat from the audience, so thank you very much for those. We'll make sure that we get to them here at the end. I think my final question here is a little bit more broad and kind of generally looking forward. I'm wondering what other research projects, any technologies, innovations that you're closely monitoring right now that you think will have a big long-term, short-term impact on the GI community. This could be happening with your team under your own roof. It could be happening at the institution of one of your colleagues, but just anything that you see as being on the horizon for kind of a game-changing next break in the field of GI. Maybe I can start with Dr. Eswaran and move on to Dr. Sharma, and we can round things off with Dr. Spiegel before opening it up to the Q&A.
All right, thanks, Craig. So I guess two things that I think are probably next steps, at least in my space, would be kind of trying to refine the low FODMAP diet or other dietary approaches for IBS. So the low FODMAP diet is effective in many patients with irritable bowel syndrome, but it's such a blunt instrument, and it really just is not very elegant in terms of how it improves symptoms. And so really, I think next steps in terms of that space are to really figure out what elements of the low FODMAP diet you really need to take out in order to confer the same or close to the same sort of benefit that you might get with a complete elimination. And so there's two ongoing studies, one from our group, one from Belgium at DDW, that we're trying to like kind of chip away at this. But I think when those are complete, that would be really interesting to see, so we can kind of really figure out if we need what of the low FODMAP diet is really necessary for most patients to still achieve that benefit. And the other thing that I think other area that I think would be really helpful is really trying to figure out why some people respond to some therapies and why not. So we can kind of give a more tailored approach up front and curate their care from the beginning, whether it's based on symptoms, some sort of genetic signature or microbial signature, or other diagnostic tests that can really kind of make their care more niche rather than kind of shotgun approach. And so I think those two are the main areas, and there's a lot of things going on in terms of diagnostics to hopefully be able to predict best outcomes.
Yeah, no, that's tremendously helpful. Thank you. And this idea of kind of an individualized or precision-based approach to the GI patient is one that is fascinating to us. So we appreciate you shining a light on the fact that that's a much needed area of research and one that I think is continuing to advance. So thank you. Dr. Sharma, same question to you. New technologies, new areas of research, things that you're keeping a close eye on and see as having a direct impact on your practice, either over the short term or the long term.
Sure. I am a big believer of focusing on the gut-brain axis, to making sure there's any immersive technology which is in that field, maybe a phone-based CBT, or even using a psychologist through telemedicine to make sure that people get their any stressors addressed. That's something I'm watching very carefully, something which is scalable, where I can take care of multiple patients at the same time. That's something of very keen interest to me. And number two, I'm watching Brennan's VR progress, and hopefully going to bring that over to my practice and other practices across the country as well. Because I think this is a perfect time. We live in such a digital age. Anything which is absolutely immersive and patient-centric, I think will be helpful and will be a big hit with the patients, because it puts the remote control in the patient's hand. And that's what we want, is because it'll improve the quality of life just by the perception of being in control.
Absolutely. That empowerment of the patient is so important. We appreciate you offering that insight. Thank you. And Dr. Sharma, I actually am happy to look at a comment in the chat box here asking the title of your latest book on probiotics, if you could offer that to the group.
Absolutely, yeah. The book is called Pursuit of Gut Happiness, because I just could not come up with the name. So I just put 3 common words together and came up with the name for the book.
Got it. Never works. Well, Dr. Spiegel, please, if you could kind of finish things off with the same question.
Yeah, I'll be brief. I'll be specific. So I see one of the questions is are there novel diagnostics for bloating, for example. And I'm a little biased here because, I did invent a biosensor. Happens to be sitting right here. But the point, I don't want to sell any biosensors here, but the whole idea is, again, putting the remote control in the patient's hand. This Abstats device, which we're working on and is actually FDA cleared, is a sensor that goes right on the belly. And it's simply a microphone. It listens to borborygmi, it listens to bowel sounds. It's kind of a Fitbit for the stomach, for the abdomen. So we can count how many bowel sounds there are per minute, and we call that the intestinal rate, or IR. And so the idea there is it's like a stoplight. For starters, as people are thinking about when should I eat my next meal? Well, if you're still digesting your last one, you get a red light, you shouldn't be eating the next one. There's a circadian rhythm, and the psychology of eating could care less about the physiologic needs of the patient. And for people with IBS, functional GI disorders, bloating, just getting back in line with sort of circadian digestion, I think is a good idea. But also to understand what is happening in the gut at any particular moment, and how can that be used to sort of guide a more precise decision-making. And we don't have the answers to all that yet, but we do have the measurement stick. And that's what this device is. And I think, we'll learn more as we continue to experiment with it and test it.
No, that's so helpful. We appreciate all of the panelists' responses here with so much heterogeneity riddled throughout the different disease categories for a GI patient. Knowing that there is kind of a cohesive school of thought around what the future can look like is really, really important, and ongoing monitoring and technologies that provide a means for a patient to do so continually is really, really important. So thank you very much for that. Thank you to all of our panelists. Johannah, I know we have a few questions here in the chat box. I think maybe we can open up the Q&A session here now and start with some of these questions from the audience.
Let's do it. So Dr. Spiegel, first one for you. And since we have a lot of questions and maybe only about 10 minutes, so let's see how many we can get through. But Dr. Spiegel, at what point do you test for SIBO? After trial with low FODMAP diet doesn't help, or before?
That's a good question. It actually varies a bit for me, to be honest. I don't have an algorithm. I think about, first of all, if bloating is a predominant symptom, I tend to be a little more interested in checking for SIBO. If the symptoms are severe, I'm thinking about testing for SIBO. Not that SIBO is always severe, but when people have certainly failed first-line therapies, I think about it. I don't always check for SIBO before I treat with antibiotics, but sometimes I do. because it helps me make that decision. It helps the patient understand why we're doing it, and it can be used as a biomarker to monitor patients over time. So I have to be honest, I don't have a lockstep algorithm for when to do this, and including around FODMAP, I don't necessarily check before or after a low FODMAP diet. I kind of independently treat with a low FODMAP diet separate from the breath testing, but that's my own practice. I do still test for bacterial overgrowth for sure, but not necessarily to decide about the low FODMAP diet. That's my own practice. Others may be different.
Okay. Okay, that's great. Dr. Eswaran, I'm going to send this one your direction. 2 questions. What workup do you recommend for functional dyspepsia or postprandial distress syndrome? And specifically, how far do you have to go in the absence of red flag symptoms before you stop evaluation and just focus on treatment?
Yeah, that's a really interesting question. I would say after the standard, upper endoscopy plus or minus gastric emptying study for functional dyspepsia, I think that's kind of when I start to have a conversation about what functional dyspepsia or postprandial dyspepsia is, and how that might relate to, again, what we're eating, the type of food we're eating, and then also its relation with the brain-gut interaction. So I kind of at least start bringing it up fairly early in my relationship with the patient. After those first 2 things, that's probably when I start to talk about it. But kind of similar to what Brennan was saying, I don't do the same thing for every patient. It's kind of a feel, and depending on some of the other red flags, yes or no.
Okay, that's great. Dr. Sharma, can you repeat again the brand name that you used for BSL number 3 again? That was a question from Pamela. I don't recall what that was in relation to in your conversation, but if you recall.
Yes, absolutely. I'm going to actually give you a little secret.
Oh no, Dr. Sharma is frozen.
I actually take a probiotic. Oh, am I back on again?
You're back. Okay, go ahead.
Okay, great. So, VSL number 3 was the original brand, but now it's called Visbiome. V like Victor, ISBIOME, Visbiome, and it's a medical food where they have billions of CFUs of multiple genus and species of probiotics. I always like to mix them up, and I always get good results when I mix Lactobacillus bifidobacterium, Saccharomyces together, and I've had good results with it.
Okay, that's great. Thank you. Dr. Spiegel, I'm going to ask this one from you. Can you please speak to the topic of mast cell activation syndrome and its possible relationship or overlap with IBS, particularly the incident of IBS symptoms during MCAS flare-ups?
This is not an area I know much about, so it's hard for me to answer that. I mean, there's been efforts over the years to look at mast cell stabilizers in the management of IBS without much success. Unfortunately, we have not found that, these same medications used in asthma, let's say, leukotriene receptor antagonists and so on, have helped with IBS. But there are certainly mast cell related conditions, but I'm not an expert enough to answer that question.
Okay. What about anyone else on the panel? Does anyone else feel like they can speak to that question, Dr. Eswaran?
Well, I'm glad that Brennan got that question before I did. It's a difficult question to answer. I know that you can have mast cell activation syndrome and GI symptoms, and there probably is some overlap with MCAS and IBS. And there may be also a lot of patients with IBS that we're calling IBS that actually have mast cell activation syndrome. But the diagnostic criteria for that entity is a little bit fuzzy when you talk to the allergists who treat mast cell diseases. But some patients do get better with things like swallowed cromolyn, for example. But generally at my institution, it's the allergists that are recommending that rather than the gastroenterologist.
Okay, that's great.
You know,
Oh, go
so,
ahead.
you know, so I actually have some experience in this food allergy mast cell immunological pathway.
Mhm.
I actually have two patients in my practice where they went to see the allergist. They went on the elimination diet, nothing helped with them. And as I paid attention to the symptoms, I discovered that right when they ate a certain food or a bunch of things, they would get pain and discomfort 25 minutes later. So, then I'm like, you know what, let me try something different. I actually put them on Benadryl. I had them take Benadryl 12.5 milligrams 1 hour before eating. Voila. I felt like a superstar that day. So if we're dealing with histamine, allergy, leukotriene, some type of pathway, I feel that would be interesting to try some Benadryl, see if that helps them, make sure they're not driving after that. But if that helps, because that also tells me another thing, which is, would they be at risk for anaphylaxis with food, right? If Benadryl is working for them, it means if at some point mast cells get activated, do they need to carry an EpiPen with them? So I actually made this patient also carry EpiPen with them as well, just for safety. They never used it, but it makes me feel better that now at least I have some handle on things where it's some type of a histamine, leukotriene inflammation, immunological pathway.
That's very interesting. That's fascinating. I think we're going to see, I've seen several studies that are ongoing right now related to mast cell activation. I think we're going to see some interesting things in the next couple of years on this topic. So that's really interesting.
Absolutely. Yeah. You know, another thing I want to add is, if I have a few seconds, like it's a big part of my practice as part of IBS workup. If they don't feel better, they continue to have symptoms, I actually run a special food allergy panel. And LabCorp has a 96 IgE panel, which they run for food allergies, where they check for peanuts and almonds and cashews and things like that. A lot of times I have identified IgE antibodies to a certain food item. And when I've removed that or taken steps to avoid that or mitigate that trigger, I've had good results with it. So just a food for thought.
Yeah, that's interesting. Thank you. Thanks for sharing that. All right, so we only have a couple of minutes left. I just wanted to ask you all about how you're handling virtual visits. I know, COVID is starting to dissipate a bit, but some patients prefer to stay on that telehealth for reasons that Dr. Eswaran mentioned earlier. They find it more convenient and less maybe exacerbating to their symptoms, having to travel and anxiety of going into a clinic situation. Are you planning on continuing virtual visits and follow-ups with your patients, or are you planning on starting to wean off of those? How are you planning to continue that? Dr. Eswaran, I guess I'll start with you.
Oh, yeah, thanks. So at Michigan Medicine, in my clinic in particular, we are planning to continue telemedicine in some capacity going forward. It makes a lot of sense for patients who travel really all over the state, from some parts of Ohio to come and see us. So it really, I think, will improve our patient access, patient adherence, and also patients who won't become lost to follow up because of that. So, personally, I think it's a great thing for patients and me as well. I kind of enjoy that variation in my work week. And so I think it's here to stay, and COVID kind of ushered this in for us.
Yeah, I would agree. Dr. Sharma, how about you? How many patients are you still going to see virtually?
Since I'm in private practice in the middle of cornfields, I'll make sure I clarify that it's in the cornfields. Sometimes the Wi-Fi signal is not strong, so the quality of visit is not very good. So at this time, about 99% of my visits are in person, and people actually prefer that. They just feel more satisfied that way, because my practice is different than Shanti's practice. We kind of draw from more of 60-mile radius versus theirs, more global radius. So people like to come in person, better quality of care, and then at the same time, technical issues. And then from me also, practice revenue standpoint too, I'm sure there's some listeners who are in private practice. Some insurance companies, they're trying to kind of adjust the payments where a virtual visit may be paid less than in-person visit. So I think that may have a factor in for guys like me who are in private practice as well. So it's a complex web of things.
Sure. And Dr. Spiegel, what is your institution doing?
Yeah, so it's been interesting because we've had great success with virtual visits. And now that we've gone back largely to in-person visits, we've actually found that about 50% of our patients prefer virtual visits. And now we're left with a hybrid clinic. So half of our patients come in person and the other half don't